topic in two sections. One is building the foundation. We need to understand what it is. And I know there are some BNB students and so on, so I'll be going back and forth between a bit of basics and into advanced things. And then how we use this theory in practice. We'll start with the theory in terms of building foundation. We'll be talking about 4 subtopics in each topic. So 2 types of epilepsy, dialectic seizures, the impreciseness of epilepsy syndromes, and then we'll talk about prevalence and prediction. So these are the 2 kinds of epilepsies that we have been taught. Whether these 2 distinct categories, they are not overlapping, they are very distinct. One is a focal epilepsy that starts in one part of the brain, and the other one is a generalized epilepsy, which for some reason starts all over the brain all at once. If you look at the seizures, and let's start from the point of seizures. If you look at seizures, then seizures themselves are classified into 2 types. Focal seizures, generalized seizures, and then seizures for which we don't know the onset. And this category is very important. Focal seizures are mostly described by the seizurology. So, for example, atonic seizures, clonic seizures, and so on. And then generalized seizures are also described by the seizurology, but then within that, for absence seizures, we have different classifications. I think you need to remember within generalized seizures, 3 important subtypes. One is the generalized tonic-clonic, one is the myoclonic, where you get like sudden jerks like this, and one is the absence seizures. So at this point, when we are talking about absence seizures, we are talking about generalized seizures causing a loss of awareness, so absence. And so the IID recommends that once you diagnose a person with these kind of seizures, then you try to think about what kind of epilepsy the person has. So let's say the person has many different kinds of seizures, but they are all generalized. Then you say, fine, this person has a generalized epilepsy, an epilepsy that starts all over the brain all at once. And then later, there is a 3rd degree of complication. You say, well, this person has some unique characteristics. This person has some unique EEG. This person is intellectually impaired. This person has critical facial features. And it's in considering all the constellation of symptoms, let's put all of these group of people into a separate category. And you call that the epilepsy syndrome. So there is the seizure, there is the epilepsy and epilepsy syndrome. This might seem simple, but it's very important when it comes to treatment pain. When you talk about epilepsy with generalized seizures, there are these 3 subcategories, if you will, of the epilepsy syndromes. One is the worst. You see them occurs in children. That is when the epilepsy itself causes problems with thinking, memory, development, etc., etc. And you call them the epileptic encephalopathies. These are horrible. The West syndrome, Landau-Kleffner, up to a certain extent, Lennox-Gastaut horrible as well. And then there is this other category that is more prevalent in the older population. So you call them the idiopathic generalized epilepsies. And these are 4 different categories. We'll go over them. But as a group, they tend to be much less severe as compared to the previous group. And then there is this intermediate group, G1 syndrome, sunflower syndrome. These things are very rare, the intermediate group. You'll see maybe 1, 2 in your lifetime. But these are the things that people try to interest you with. But you don't really need to know them in day-to-day practice. The second point is about dialectic seizures. How many of you use that term, dialectic seizures, in practice? 1, 2 maybe. Sir uses them. So, the question is, if you are unsure, if you don't know, isn't it better to say I go flow rather than make some commitment that, and then be completely wrong about it? So, when a person blanks out in front of you, in front of the parents might tell you this kid, this adult is blanking out. You actually don't know whether those seizures are starting from one place or all over the brain at once. And we'll talk about what that means. But basically, it would be a focal onset seizure with impaired awareness, or it could be a truly a generalized absence seizure. Now remember, I'm using the word seizure. I'm not using epilepsy, because absence seizures, as we will go forward, happen in many different kinds of epilepsies, not only in absence epilepsy. They can happen in juvenile myoclonic epilepsy, they can happen in juvenile absence epilepsy, they can happen in Lennox-Gastaut syndrome, and this is complex, but it will become a bit simpler later on. Suffice to say that the historical description of seizure does not tell you anything about where this is starting from. The concept is important. The concept is we cannot make precisely right each time, especially when it does have the history to go along with. So even IID makes the same point in a different group of people. And I'm just going to read this is verbatim from the ILAE guide text. Clinicians often commonly hear about tonic-clonic seizures for which the onset is unobserved. the person is found in the bathroom or wherever it might be. The task force recommends classifying the seizure as having focal or generalized onset only when there is a high degree of confidence in the accuracy of the determination. Otherwise, the seizure should remain unclassified until more information is available. Again, don't commit yourself to a specific category or a specific group of medications without making sure. We'll talk about epilepsy syndromes, and then, we have been taught about 4 epilepsy syndromes in terms of idiopathic generalized epilepsy. The childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. And these definitions have been made by human beings. There's a lot of imprecises between them. In fact, the very name of this category keeps on changing. In 1989, they came up with this name idiopathic. हम नहीं जानते क्यों है, मगर ऐसा generalized seizure होता है. And then there was this expert confidence in genetics. Oh, now we know. Now we are going to be genetic in nature. Genetics is going to take over. And so we started calling them genetic generalized epilepsies. But then they said, in some countries, especially India, genetic has a negative connotation. People will not get married and so on. So they went back to idiopathic generalized epilepsies. So don't get confused. All of these terms mean the same thing. There are 4 major categories that happen in adults. The most common is juvenile myoclonic epilepsy, which I think all of us, including the BNP students, have seen by now. But there are other categories, including juvenile absence epilepsy, childhood absence epilepsy, and epilepsy with generalized one seizure something. Now, the key to see is that if you look at the column of seizure types, if you look at juvenile myoclonic epilepsy, does that contain absence? Yes. So, juvenile myoclonic epilepsy can have absence seizure. Childhood absence epilepsy, we have been taught that in childhood absence epilepsy is in condition where the person just ranks out. But many of them, as they become older, they develop generalized convulsions. Juvenile absence epilepsy, one of the classical things is that it has more chances of having generalized one-to-one seizures as compared to childhood absence epilepsy. So it is the predominant seizure type that makes you determine something as a particular syndrome. That might be true, but then we also see this phenomenon that many people who you earlier diagnosed with childhood absence epilepsy, they only had childhood absence epilepsy, only had absence seizures, I'm sorry. But then as time goes on, they start knowing myoclonic jerks as well. So what do you call them? And this happens in real life, no matter what we want to happen. What do you call them? Do you call them childhood absence epilepsy with myoclonic jerks? Or do you call them, अरे मेरा गलती हो गया था, ये तो पहले से ही juvenile myoclonic epilepsy था? We don't know. People call them by different names. Suffice to say that I think I have made my point that don't stick to one epilepsy syndrome and decide that this is the epilepsy syndrome, no matter what, I'm going to treat only with this group of medication. In terms of preventive prediction, is it really a problem? Because idiopathic generalized epilepsies, we have been taught they are very easy to treat. Ethosuximide, they don't Levetiracetam, they don't, all of them did better. All of them did better than what you have been taught. But it's not so. Now, when you look at the prevalence, how common is it? You need to make sure that you know what kind of study you are reading. If you are reading a hospital-based studies, these are severe patients with severe problems. So some of the hospital-based studies have a prevalence of resistance as high as 50%. Now, how many of you believe this study that 50% of patients with generalized epilepsy have resistance? Anybody? Nobody. Nobody believes that. Okay. A figure of 20 to 30% is often cited, but is this figure correct? If you look at the population-based studies, that figure is correct. About 24% of patients in this study, which was done in Denmark, so European populations, national healthcare systems, all the data is known. About 24% of patients had resistant epilepsy. But if you go into the death, 12% of them had pseudo-resistance. They were just not taking their medications on time. And 12% is probably overall in idiopathic generalized epilepsies, the true representation of how many patients are resistant. And I think that matches up with my practice. About 1 in every 10 patients with idiopathic generalized epilepsies tends to be 1 in 10, 2 in 10 tends to be resistant. Can we predict beforehand? Ye particular aadmi is diagnosed with some kind of idiopathic generalized epilepsy, whether it be childhood, absence or whatever, is going to be medically resistant. So yes, if you have juvenile myoclonic epilepsy in which absences are very common, for example, then resistance is very common. The very presence of absence seizures makes it more likely for the person to become resistant. psychiatric comorbidities, catamenial epilepsy, status epilepticus. These are probably important, maybe not. But absence epilepsy in juvenile myoclonic epilepsy is a red line. Within the EEG, there are two features. You get this faster activity. And if the faster activity lasts for more than 1 second, we call it generalized paroxysmal fast activity. If it lasts for less than 1 second, we call it GPT, generalized polyspike-wave. The same sort of thing. If these things are present, then it is much more likely that the person will be medically resistant. A small note about GPFAs. First, we were taught that they happen exclusively in Lennox-Gastaut syndrome, but that's not true. They can happen in other idiopathic generalized diseases as well. This is a nice thing that I saw. So in GME, the longer the polyspike duration, especially if they're very long, they tend to be medically resistant. And since I read this, I found this should be true in my practice. All of this theory is nice. But this is all theory. What do we do in the individual patient? So let's talk about the basics. We'll talk about 4 subtopics. One is that we have always been taught that use a syndrome-appropriate AED. Look at the seizures, diagnose the epilepsy, try to classify the person into a particular syndrome, and then choose the anti-epileptic. So, for example, if you are diagnosing somebody with idiopathic generalized epilepsy, choose one of the broad spectrum anti-epileptics, right? Don't choose one of the narrow spectrum anti-epileptics. We couple with using the narrow spectrum anti-epileptic, this mostly for the BNB students, is that sodium channel blockers can exacerbate primary generalized epilepsy, especially the myoclonic kind of seizures and the absence kind of seizures. So you don't use narrow spectrum anti-epileptics in idiopathic generalized epilepsy. But is it nearly never use them? We'll talk about it. So these are the standard recommendations in terms of the epilepsy syndromes. But where do these recommendations come from? Which is more effective than the other? So this is about childhood absence epilepsy. They compared 3 medications, Ethosuximide, Valproate, and lamotrigine. And lamotrigine was nowhere as useful or nowhere as effective as Ethosuximide and Valproate. Within Ethosuximide and Valproate, there was very little to choose, but the incidence of side effect was greater with Valproate. Now, one thing to remember, and we come back to this, is that Ethosuximide treats absence seizures. It does not treat generalized convulsions. So now going back and tying it to the theory, we talked about how some people with childhood absence epilepsy will have generalized convulsions. So will you choose Ethosuximide for that patient? Anybody? It treats only absence seizures. So perhaps something else Valproate might do better. In terms of juvenile myoclonic epilepsy, yes, Valproate, there might be people who recommend Levetiracetam, use Levetiracetam, but Valproate is the most effective medication for juvenile myoclonic epilepsy, bar none. But let's say I had epilepsy, you had juvenile myoclonic epilepsy. Which is the medication you would like to take? Would you like to take Valproate or would you like to take Levetiracetam? Anybody? Anybody who would like to start with Valproate for yourself? I think that's right. Dumb from, no? BSL. So, and one could be. You are 10 people, so but Valproate has a lot of side effects, and that's the thing why you might want to avoid it. Lamotrigine, of course, it is mostly for the LND students. Again, we talk about how sodium channel blockers and lamotrigine, one of the actions is sodium channel blockade, and then it can exacerbate myoclonic and absence seizures. And then in GDSA, it's kind of you can choose whatever you want. Rowley Valproate is more effective. There are these other medications which can also be given as add-on medications: Zonisamide, topiramate, clonazepam, berampelin, primidone, and cinobate. As we talked about, when you see a person with resistance, half of them are severe resistance. They are not taking their medications on time. So how do we improve the compliance of patients? First of all, you need to simplify the dosage regimen. Use once a daily medications in these patients, maybe sustained release titrations or whatever. But especially don't do TDS dosing. Keppra is Levetiracetam anyway is not supposed to be given TDS, and everybody forgets the afternoon dose. Talk with the patient, tell them, kya hota hai. You get weird side effects like hair loss with Valproate, Levetiracetam. Maybe you can shift them over to something else. You can keep pill boxes and so on and so forth. And depression is a major factor. But what trick can you use to maybe make the medications you're giving more effective? You can look at the half-life. And if you look at the half-life, The half-life of Zonisamide is 50 to 70 hours. And the half-life of penicillin is 105 hours. So if you have a non-compliant patient, then perhaps you should be turning to these medications very early on. These are once-a-day medications. Let's say the patient misses single dose, probably nothing bad will happen to him. Primidone and phenobarbital are to be reserved for your NAEs. Don't give them. If you really don't like a patient, perhaps. Second thing, if you try these medications, you should be considering this diagnosis. Have I diagnosed this person properly? So we'll talk about three things. We'll talk about glucagon deficiency. We'll talk about myoclonic epilepsy and so on. So the easiest way to remember group 1 deficiency is this is a childhood advanced epilepsy patient who doesn't seem right. कुछ तो गलत है. नहीं कुछ तो गलत है या ऐसा वैसा हो सकता है. This person either developed epilepsy too soon at the age of 2. That person starts having absence seizures. He starts having some movement disorders when walking. His scoop will suddenly twist. Paroxysmal kineseminic dyskinesia. They might have atypical absences. They go on for very long. Or if you Ethosuximide and nothing happens, this patient does not respond at all. Then you need to think, kuch to galat hai, do a lumbar puncture, find low glucose, and then possibly start him on a ketogenic diet. There is also, and this is resistant childhood absence epilepsy, right? There is also resistant juvenile myoclonic epilepsy. So 70-year-old, this is a patient of mine, 70-year-old male, onset was at 16 years of age. He had myoclonic seizures, absence seizures, and generalized myoclonic seizures. But he also used to see rainbow colors before the generalized myoclonic seizures. And lamotrigine, of course, can cause worsening. It causes worsening of all seizure types. But this patient also has mild cognitive deterioration, and the sister has similar symptoms. Similar symptoms. I think the sister was slightly more intellectually impaired than this person. So what now? What would you do now? Anybody? Next is genetic justice. Anybody else for lumbar puncture? Genetics has taken over everything. Na? So, of course, we find this and there's 5 pure discharges, but in this particular patient, we also found occipital discharges. And this person had progressive myoclonic. So, we used to think of progressive myoclonic epilepsies as these uniformly horrible conditions in which all patients die in early childhood, but that's not true. In Ukrit lupus disease, in Lafora body disease, you certainly can find a subgroup of patients who make it all the way into adulthood and can survive for a long time. There are now particular genetic mutations identified that are associated with a milder phenotype. So think about genetic testing even in cases of idiopathic generalized epilepsy. So this is one of patient of mine. These are non-epileptic seizures. This was a patient in my clinic 4 years ago. 76-year-old male, and he used to go like this every 5 minutes. So every 1 hour, something in that, multiple times an hour. And he had third-degree AV block. The drugs had possibly nothing biologically to do with the AV block, but he felt he was being cast out. And he did something. This is called elaboration. He kind of elaborated on his symptoms with something we can't explain biologically, but was diagnosed with juvenile myoclonic epilepsy. Myoclonic epilepsy to begin with, I shouldn't say juvenile, but it's 76, but he was being treated with ankylate. This is a person, again, my 9-year-old girl, not last week now, it has been a long time. Repeated episodes of blanking out and blinking, especially when stressed for 3 years. MRI was normal, EEG was not. MRI was normal, EEG was normal. Partial response to Valproate. What would you do next? A routine EEG was normal, did not capture any image. Video EEG? Anybody for genetic testing? First, we need to characterize what kind of events this person had, right? This is an event. These are right temporal lobe seizures. Remember what I told you about ILAE seizures. Much better to say, I don't know. This person is probably too old, slightly on the older side to be having childhood absence epilepsy, maybe don't know the juvenile absence epilepsy. But I think it's important to say, I don't know, and let's do an EEG and find out what this person has. So now a lot of sheets open up for this person. You could give carbamazepine or whatever you want, whatever is your girl of choice. So there is no room that young girls or young children cannot have temporal lobe. Of course they can. Now, we talked about syndrome-specific anti-epileptics. Let's talk about seizure-specific anti-epileptics. And I alluded to one way in which you can use it. even though we have been told all our life that Ethosuximide is the drug of choice for childhood advanced epilepsy, if this person now starts developing generalized convulsions, what is the drug of choice? Anybody? Valproate, right? Because Ethosuximide works only for advanced seizures. It will not work for generalized convulsions. In this particular child, young child, you need to treat a generalized convulsions also. You never focal anti-epileptics is what we said. But is that now? There are some things I am scared of. But let's talk about that. So 26-year-old genius, seizure onset at the age of 30 years. He had myopathic seizures and generalized pulmonary seizures. Normal MRI, EEG showed generalized spike-wave discharges, photoconcentrated response. So you do photic stimulation, you get those epileptic discharges. What would you diagnose this patient as? Juvenile, right? Everybody agrees? Now, but this person has failed Valproate, Levetiracetam, Lamiprazole, Zonisamide, Topiramate, Phenobarbital, Primidone. What will you do next? Fail means combination. This is a published case, not my case. Everything, combinations, high dose therapy does not work. And this is poor resistance. I mean, you're compliant and everything. We talked about it. About 12% of patients do have poor resistance. You don't know exactly why. We have some predictors to predict, but you don't know exactly what's correct. And genetic testing was negative, so it doesn't have progressive myoclonic estimates. What would you do most? We in the Q1, let's say, and I don't remember whether that was in the point. In this particular paper, carbamazepine for treatment of generalized tonic-clonic seizures in idiopathic generalized epilepsy, they actually treated such patients with carbamazepine. And they found that it decreased the incidence of generalized tonic-clonic seizures. So there is this group of patients whom generalized tonic-clonic seizures will be the major component of penalty. And the advanced seizures of generalized seizures will just follow component. In that case, perhaps treatment with generalized convulsion actually help. Now, I told you I was upgrade at this. I don't do in practice. I see some skepticism on surface, which is completely fine. But this is what is focused in the literature. This is what some people are doing, including Dr. Mani, for example. So every time, anybody who has tried to call anti-epileptics in generalized epilepsy? Nobody. But some people do use it. Not unless I'm sure that.
But yeah, we see patients, if you withdraw the drug of in generalized seizures, carbamazepine withdrawal causing seizures, we have seen that.
Very nice. I have seen that myself. Therefore,
so there we have seen.
Let's say you consider yourself to be this big neurologist, big epilepsy person, and some general clinician has started carbamazepine for juvenile myopathic epilepsy or something. This is गलती किया है, बंद करनी है. बंद करो, ये बेची है. You get see and they won. So the question is, are there such things as truly generalized epilepsy? How can you have the entire train carry off at lunch? There must be some single source from which these abnormal signals start. So all the way back to Jasper, people have been trying to find out where idiopathic generalized epilepsy starts. Jasper actually came up with this centricephalic theory that something is wrong in the thalamus. And then from the thalamus, the cortex is stimulated in a volley of impulses. And then there have been many modifications to that theory. People found out that within the thalamus, the intralaminar nuclei are important. Intralaminar nuclei, out of which the centromedian nucleus is one. And then they figured out many different theories. So perhaps this is the most recent theory. This is one in and this helps us understand why perhaps focal anti-epileptics might work in idiopathic generalized epilepsy. So the theory is that there is this focal cortical agent that happens. It gets propagated to the thalamus, and then via cortical connections, the entire cortex is primed for having seizures. And then the volley starts. But what is the key thing to remember? That it is a focal cortical event to begin with. Can we use this in practice? So, sir, and Wiley, Ravishankar Saraj, and Wiley, who is at Cleveland Clinic, they actually published a set of patients who were initially diagnosed with idiopathic generalized epilepsies. They bring an MRI on them. They were MRI positive, most of them, all of them again. And then all of them had MRI abnormalities. And then you remove the MRI abnormality. And they became seizure free. You remove the cortical MRI abnormality and they became seizure free. What does that mean? It was starting from the cortex. And these were patients who had hypercell prevalent clinic, big centers, idiopathic generalized epilepsies get better. In fact, and seizure freedom rate was very good, 72%.
अरे सिद्ध
50% उसको तो all population
Use?
elevated.
So in terms of those patients, it's a multiple seizure phase, tonic, atonic, echinocandal, spasm, IGDT, and some of them did not supergender.
This was that.
माइक अपन माइक
But basically, this paper, Ami said that the patient with focal epilepsy, especially early onset, then have generalized this study. That is not the continuity.
We'll come to that. We'll come to the difference of opinion about what this paper actually means. So the seizure freedom rate was 72%. And subsequently, Radhakrishnan sir actually published a set of places. As sir said, at the very basic level, you could say that this is epilepsy which has generalized features, but which later on turns out to be focal. We have accepted like some syndromes that we considered to be generalized earlier, like West syndrome and Nandu-Plessner syndrome, do get better with epilepsy surgery. But with these studies, we should be looking more closely at MRI positive, quote-unquote, idiopathic generalized epilepsies. The question is, should we also be looking more closely at MRI negative idiopathic generalized epilepsy? And as sir said, and this is where Skyboon comes in handy. What to do with this data? What to do with this data? Now, at Cleveland Clinic, I understand, sir, why he interpreted it in a different way, but there are some other people who are arguing about it in a different way. These are the pre-teens. So one person will say, won't be full. Idiopathic generalized epilepsy has focal seizures, EPGP record. Right side degradation, everything, everything is generalized epilepsy, but some pensive focal symptom. There are some people who say, many negative generalized epilepsies originate from the cortex, don't looking for a focus could say. There are some people who say both of them can happen in the same person. There are some people who say there can be misdiagnosis, and some people just focal epilepsy or misdiagnosis with idiopathic generalized epilepsy. We don't know. And I think keeping our mind open to new ideas is the most important thing. Perhaps it goes on to focal epilepsy. In terms of desperate measures, if nothing else works, what do? We can think about neurostimulation nowadays and diazepam. So in terms of neurostimulation, BNS in Levetiracetam, all of us know this. It decreases the risk of atonic low attacks especially. And the efficacy genetic generalized epilepsy might be the same as Levetiracetam syndrome. This is more interesting. We look at the theory and how spread of the cortical discharges through the thalamus and then to the cortex again and again can be to seizures, can propagate seizures. So what if we stimulate that part of the thalamus which is responsible for propagating these events? That is the interliminal nucleus of thalamus. That is the centromedian nucleus, which is one part of the interliminal nucleus. And deep stimulation or responsive stimulation of the centromedian nucleus might help with these kind of seizures. And I think we have started doing it in India. Sir might have more information. Have they been any done in India for idiopathic generalized epilepsy? BES? Right. I think there was one done in Delhi. Huh? Yes, sir. I think there was one done in Delhi. So, in Fisher et al., which was the original indication for DTS, there was only a 30% reduction. There is some indication that it might be even more effective than ganglion nucleus stimulation. Though recent trial showed only 50% reduction. We don't know. The RNS is again one more device that can be used for this purpose. L-Stupor. Ketogenic diet can help in many of these patients. Classically, it helps in group 1 deficiency where the glucose transporter taking glucose into the central nervous system is missing. So you give ketones instead and the ketones go to the brain and nourish the brain. But it can work in all other kinds of epilepsies as well. And it is extraordinarily effective, except it is very difficult to treat. So what does all of my talking mean? No? And this is a summary. I think we should err on the side of not ruling out focal epilepsy. I think that is a statement that Dr. Rathod would completely agree with. We should always not stop looking for a focal epilepsy. Do a seed-deprived EEG because the chances that you will find a focal abnormality are higher. Confirm compliance. Give a syndrome-appropriate EEG. But if you are really in a fix, perhaps feeling a seizure-appropriate EEG is also reasonable. You need to reevaluate your diagnosis every once in a while we need to be really monitoring a bit more liberally to find a focus to characterize the epilepsy. Genetic testing is easily available. The last cost I heard was 12,000 rupees for whole exome sequencing. It should be doing it more often. And neurostimulation, including VNS, is actually approved now. It's not approved, but it actually works for idiopathic generalized epilepsies. And ketogenic diet is something that can be done to decrease the rate of seizures in this range. That's my count. Thanks, sir.